first session of the third is a scientific session 4, and this is how to proceed. And we have two wonderful learned speakers. To chair the session, I invite Dr. L. Srinivas Murthy from Bangalore, Dr. Anuradha Kapoor from Mumbai, and Dr. Akash Singh from Bradra to chair the session. So we can request Dr. maybe Dr. Ketan sir, please do the honors. And okay sir. So I request Ketan. I request Dr. Ketan sir to start the session. Thank you.
I invite Dr. Santosh Kumar Swain for his speech. Hello. I invite Dr. Santosh Kumar Swain for his talk. Please come. Yes, go ahead. Thank you.
Thank you, Chairpersons. At the outset, I thank our visionary Dr. Professor A.N. Rai. For his effort only we are enjoying this academic feast, and Dr. Burmani sir for planning the excellent academic program with the clinical touch and with wide hospitality. So the topic was given for assessing the preoperative management for a 65-year-old diabetes of 15 years duration. So I will touch on the following content. Introduction: why is assessment important in the case of diabetes in a surgical setting, what to assess, and the practical managements before surgery, and the guidelines in the preoperative and perioperative period. So just to brush up with the vitals, statistics. The 10th edition of the IDF has given the data that 537 million people are diagnosed by the year 2021, and the figure will increase to 643 in 2030 and 783 million by 2045. And India ranks the second number and will continue till 2045. So introducing the case, the diabetes patients suffer from cardiovascular and microvascular complication. Need for surgery is more often than the non-diabetic patients. Known or unknown diabetes increases the perioperative risk from the surgical procedure themselves, the anesthetic drugs, the fasting, the multiple infusions, and the associated treatment and stress. So therefore, diabetes patients should be given special attention before, during, and after surgery. Why is the assessment of diabetes important in the surgical setting? Surgical procedures result in several metabolic perturbations that can alter the normal glycemia. The abnormal glucose balance is a risk factor for the postoperative sepsis, endothelial dysfunction, cerebral ischemia, and subsequently impaired wound healing. Unmanaged hypoglycemia result in a number of neurological complications, which includes the somnolence, unconsciousness, seizures, and depending on the durations, at times irreversible neurological insult or at times death. Hypoglycemia enhances the morbidity and mortality in the critically ill patients, and which can prolong the ICU or hospital stay. So the response, the metabolic response, which increases the stress hormone, subsequently increasing the glucose and decreasing the insulin, producing increased reactive oxygen species and increased secondary mediators, which gives rise to cellular injury, inflammation, altered tissue or wound repair, and tissue ischemia, which prolong the hospital stay, disability, and death. Also, the increased glucose and decreased insulin lead to a immune deficiency state and propagate the infection dissemination. So preoperative assessment focus on the type of diabetes. In this case, it is a type 2 diabetes. The duration is 16 years, and stability and control of the disease, the diabetic complications presently he is carrying, and the surgical procedure which he is requiring may be a minor or major. The stability of the disease of this patient. The preoperative assessment of the microvascular and macrovascular, the blood pressure, the glycated hemoglobin, the cholesterol, the good stable control of the blood glucose not only makes for easier management prior to surgery, but also associated with improved wound healing and reduced risks of post-op wound infection. The RBS also is a guide to the perioperative management. Finally, the glycated hemoglobin is a reflection of the integrated blood glucose control, which if less than 8 is suitable for the day surgery. If it is more than 9, so the review of the status is required for elective surgery. In case of emergency surgery, we can plan out. The other comorbidities which may be inquired in this patient are the history of smoking and COPD, history of coronary artery disease and ischemic heart disease, history of acute coronary episodes, history of undertaken PCI or maybe he undergone CABG, any dilated cardiomyopathy or heart failure with reduced ejection fraction, any history of valvular heart disease or history of surgery for valvular heart disease with valve replacement, any history of other heart disease like aneurysm, etc., history of TIA or CVA, history of CKD or maintenance hemodialysis, history of cancer or continuing with chemotherapy or radiotherapy. Now this comes the history of COVID, post-COVID status, history of obstructive sleep apnea, history of major hospitalization in the past, history of minor or major surgery in the past, and history of any bleeding diathesis. The diabetic complications which can be looked for, like the acute metabolic complications like hypoglycemia, dehydration, diabetic ketoacidosis, hyperosmolar state, acidotic state, hypokalemia, chronic end organ damage due to long duration of diabetes, suffering due to microvascular and macrovascular like nephropathy, neuropathy, autonomic neuropathy, retinopathy, coronary artery disease and peripheral vascular disease. Other associated disease like dyslipidemia and hypertension. Recognition of these complications may be done by history, examination, investigation and the management, and this involves a multidisciplinary approach which the surgical team, the medical team and the anesthetic team will help. So ultimately the preoperative consideration, there is a threatening trio, means the patient can go land into problem due to this trio, as there is a silent MI which can precipitate during the major surgery, or the renal dysfunction underlying which can be elevated creatinine and subsequently land the patient in problem, and the peripheral autonomic neuropathy. Then comes the characteristic of surgery planned for this patient. It may be a minor surgery or major surgery, like cataract surgery, commonly diabetic foot debridement or amputation, hernia surgery, abdominal surgery like cholecystectomy, appendicectomy or hernioplasty, brain surgery like drainage of the ICH, EDH, SDH or any tumor resection, cardiac surgery like undergoing a PCI or valve replacement or pacemaker insertion or CABG, orthopedic surgery due to fracture, dislocation or road traffic accidents and others. And the timing of the surgery is also important. The duration of the surgery is also taken into consideration. The reason, the below diaphragm, above diaphragm, the surgery is concerned, and also it involves the anesthetic procedure like regional, epidural or general anesthesia. The detailed history of the diabetes therapy, like the insulin, if he is on insulin, we have to know what type of insulin, the dose of insulin. If he is on OHA, then what is the dose of OHA, what are the timings of the OHA. So this is a slide which concisely mentions during the perioperative adjustment, what are the non-insulin diabetic medication? For example, acarbose, and all the drugs can be taken except SGLT2 normal day prior to surgery. And if is plan for a AM surgery or PM surgery. For the AM surgery, for acarbose and meglitide, we can omit the morning dose if he is not on the diet, and for pioglitazone, DPP4, GLP, we can take it as normal even if planned for AM or PM surgery. For SGLT2, we have to omit on the day of before surgery, and for a AM surgery, we have to omit on the day of surgery, and for a PM surgery also, we have to omit on the day of surgery. What is the inquiry about the non-diabetic drug therapy? Important from the surgical point of view, they are the antiplatelets, clopidogrel, aspirin. So in case of elective surgery, we can hold at least 5 to 7 days prior. For a emergency surgery, we can plan for a platelet transfusion or so on. And if he is on anticoagulants like coumarin, warfarin or NOACs, and what is the antihypertensive he is taking, hyperlipidemic drugs, any antipsychotics, anticonvulsants, any antibiotics, or any inquiry of the drug he is taking. Coming to the investigations line by line, we need to assess the hemoglobin as a baseline. Also, the anemia speaks of the underlying renal dysfunction. Also, to guide the blood transfusion intraoperatively if there is blood loss during the surgery. TLC to look for any infection, occult cystitis, occult UTI. Urine examination also done for mitral or overt proteinuria for alerting the presence of nephropathy. 24 hours urinary protein is to assess and quantify the proteinuria. Urine ketone bodies to rule out the decay. Renal functions test like urea creatine to assess the renal dysfunction. And as usual, the fasting and sporprendial. Glycated hemoglobin to justify the good control of diabetes over the preceding 8 to 12 weeks. Serum electrolytes to assess the abnormalities due to vomiting, diarrhea, poor oral intake, tube feeding, intestinal obstruction in case of GI surgery or obstruction, intestinal obstruction, or the subacute intestinal obstruction. In case the patient is on ACE inhibitors, diuretics and renal dysfunction or insulin, we have to assess the electrolytes. Chest X-ray to rule out occult TB, presence of any pneumonia, atelectasis, aspiration pneumonia.
Sir, 5 minutes.
Investigations of cardiological importance, ECG to detect the asymptomatic myocardial ischemia, arrhythmia and block, echo for long-standing diabetes to assess valvular heart disease, systolic and diastolic function with the ejection fraction, TMT if there is history of angina or breathlessness or exhaustion, pulmonary function test for screening spirometry, forced vital capacity and FEV1, HRCT thorax in symptomatic or previous history of lung disease, now history of post-COVID status, ultrasound and CT scan screening of the organs, also test for autonomic neuropathy. So the broad management, perioperatively, they verify the target blood glucose with frequent monitoring, use the insulin therapy to maintain the glycemic goals, discontinue the OHA like bigonides, alpha glucosidase, thiazolidine, sulfonylurea and GLP agonist, consider cancelling non-emergency procedures if the glucose is more than 400 to 500 or with acute complications like decay or HHS. In intraoperative also, maintain the intraoperative glucose between 40 to 170, and IV insulin infusion is promoted as more efficient mode of glycemic control for longer or more complex surgery. In the post-operative period also, target the glucose range between 140 to 180. So management of hyperglycemia in the preoperative period involves the patient will be on insulin and admitted on the day of surgery and should continue their basal insulin dose and hold their nutritional insulin, means food with insulin. NPH insulin should be reduced by 1/2 or 1/3 prior to the surgery to avoid hypoglycemia. IV insulin is preferred mode of insulin delivery to achieve the rapid and effective glycemic control in the hospitalized patients who are hyperglycemic prior to surgery. In the post-op, insulin resistance increases so rapidly, during surgery the insulin resistance is increased. So after in the post-operative, which decreases, so we have to moderate the glucose level. So switching from IV to subcutaneous, IV insulin has a short half-life and should not be discontinued until the subcutaneous has been initiated. Timing of administration before discontinuation, 1 to 2 hours in advance for short and rapid acting, 2 to 3 hours in intermediate and long acting. Dosing, the basal component is 40 to 50% of the total dose. So recommendation for surgical outpatients, identify people with suboptimal diabetes management and refer to a specialist team for preoperative planning and optimization. Ensure the individual SDM through discussing the benefits, risk and alternatives to surgery, taking the presence and impact of diabetes into consideration. Take both the urgency of the procedure and control of and management of diabetes into account to inform the timing of the surgery. For example, delaying the surgery to optimize the diabetes management. Promote day surgery for people with diabetes using the same principle, those when considering day surgery without diabetes. Refer all patients with diabetes scheduled to undergo elective procedure necessitating a period of fasting to a preoperative assessment clinic as early as possible in the pathway. So take home message, glucose homeostasis during the perioperative period is extremely variable. So the blood glucose as well as electrolyte and acid base should be carefully monitored. Mindful of a patient's normal diabetic regimen, and after making all necessary changes during the perioperative period, the patients transition back to their normal glycemic management protocol. Careful perioperative glucose management, surgical complications as well as hyper and hypoglycemia sequelae can be reduced, ultimately improving the patient morbidity and mortality. Our aim is to prevent the mortality and minimize the morbidity. All patients with diabetes should undergo surgery before 9 hours in the morning to minimize the disruption of the treatment routine. For short procedures, which is treated by diet or MSN, so we do not require any intervention in the perioperative period.
Thank you,
you,
Dr. Santosh. Very excellent talk. Since we are running short of time, so we will not do question answer session.
Thank you, sir.
Thanks a lot.
Thank
So I would like to invite our next speaker, who is a well-known speaker, Dr. Ashish Saxena.
Very good morning, dear friends. A sincere thanks to Dr. Virmani for giving me this opportunity to come and meet all the stalwarts of medicine whom we have actually read their books, and like Dr. Khetan, Dr. Singh and all those people, and I got an opportunity to come and talk in front of them. That's a very big honor, especially meeting all people. A very important topic that has been assigned, like treatment of an elderly diabetic lean population with an HbA1c of 10.5. And when this topic was given to me, I suddenly realized that yes, I am treating so many patients who are diabetic and who are lean. Now, what is the thing that I'm missing? Or what is the thing that more needs to be added? So turning out to be a learning experience while I was going through all the slides and the articles in geriatrics and diabetic management and hypoglycemia, I come to see how we go ahead with the management of diabetes in an elderly population. Now, there are two types of populations in our elderly. We are fortunate that we are blessed with our elderly people now because of the longevity of life with good medicines. Type A and Type B are those personalities of our elderly senior people The type A are those who are physically, mental capabilities similar to many younger ones, like all those of my seniors who are sitting over here. And type B are those who are suffering decline in the physical and mental capabilities, impacting the entire system of diabetes. And it is therefore very, very important to address how to manage these population. Coming to the functional classification of our elderly population, it is on those who are frail and not frail. When we come to the independent, self-reliant, only diabetes and not a life-threatening disease, the treatment turns out to be far easier, where we can use all the alma mater which we have got, all the medicines, rather from the sulfonylureas to the SGLT2 to everything in these population. Frail patients without any cognitive impairment, they suffer from fatigue, weight loss, restricted mobility and strength, and highly susceptible to fall and institutionalize. Now this is where we know that these patients are very frail, they have a cognitive impairment. So any medicine which we are going to use among the anti-diabetic patients like sulfonylurea can cause the patient to go into early hypoglycemia. It can cause a cognitive decline further. Plus, if the patient goes into hypoglycemia and the patient is doing his routine activities, whether it's a walk or going for the washroom or a toilet, he might fall and sustain a fracture. So this is where we have to be very, very careful while we are using our drugs. Already a frail person and giving an SGLT2 inhibitor. Yes, SGLT2 inhibitors are good, round the clock, they are doing well. But this frail diabetic population of cognitive impairment, they also have benign prostate hypertrophy. They might be having lots of residual urine inside. They might be having cystitis. And these population, they usually do not have fever, and they start declining in their age and in their mental level, and ultimately it turns out to be that they are suffering from urosepsis. So this is where we need to withdraw these type of medicines and come on to those medicines which are on the best, like fill it, shut it and forget it. Those type of medicines for these are population. Another, coming to the category 3, frail patients with cognitive impairment, dementia, and dependent on caregivers. Now over here, if we are going to give an insulin which has to be given 4 times a day, it will be difficult because the patient is already dependent on a caregiver. Terminally ill patients, definitely they will be in the hospital and they will be having end-stage renal disease and other things. So here, the treatment turns out to be insulin or oral DPP-4 inhibitors. Now, what are the considerations that we go in the elderly population? Obesity, sarcopenia, insulin resistance. These patients, because it is frail, obesity is gone, but sarcopenia comes in. Very recently, I was in Delhi in one of the meetings where I met the star of 83, Mr. Kapil Dev. And what was found that he is a diabetic, and the problem, like discussed with in the previous lectures by Dr. Singh, he was suffering from sarcopenia of the bones, and he was suffering from frail legs, and his thigh muscles were going weak. Though being a star himself, being a diabetic, he has so many things into his things, but he was not being able to take care. So what was pointed out by our endocrinologist friend was his nutritional specialist is not right, and he's not taking a good physiotherapy. So this turns out to be a role. As he's growing, he's 63 years of age. So as he's growing, there are lots and lots of complications coming into the life. Reduced physical activity and unhealthy diet. What diet? The teeth are gone, worn out, the gums are bleeding, or the gums are not very healthy. What diet can they have? You told about oats. How can a person who has always been eating parathas and bread and all those things in his entire life come to oats at this juncture of his life? So this is where we need to think. Coexisting illness. Yes, almost all diabetics are having hypertension. They might be suffering from some or the other various degrees of renal failure. And after the age of 60, 1% decline starts having in the EGFR. So ultimately, if the patient is 70, his EGFR is already 60. Creatinine is 1.3, 1.4. So here we need to assess the patient. As the longevity of life increases, as the genetics and polypharmacy continues going on, giving painkillers, lots and lots of patients are on diclofenac, lots of are on ibuprofen. So these all things also think. And yes, like previously my speaker has said, COVID has also created havoc for our elderly population. Now these all diabetic complications, right from cognitive, dementia, depression, sarcopenia, osteoporosis, disability, frail and fragile morbidity, micro and macrovascular complications has to be taken care of for this elderly diabetic with an HbA1c of 10.5. Because the moment you give a sulfonylurea, which is a high dose like glimepiride 2 milligram, the patient can go into hypoglycemia. So here the doses are modified to 0.5 milligrams of glimepiride given twice a day, because glimepiride is a long-acting molecule. Here the role comes when you are giving a DPP-4, like we have the sitagliptin or the linagliptin, which are doing wonderful. But linagliptin turns out to be much safer for a creatinine of 1.3 and 1.5. These are the physiological changes affecting medications in the elderly population, like slowed peristalsis. So here, when you're having slow peristalsis, how can we give a carbose, and how can we give something which decreases the peristalsis? Then we have decreased hepatic metabolism and blood flow, so slower elimination. All these fancy new drugs which have come, like the netiglenide, like the metformin. Over here, the metformin is a very old drug, it still is used, but the newer drugs, like we have the magic pill of semaglutide, it cannot be used in these populations. Decreased renal flow, that is why the SGLT2 is not working in these elderly population, and as the age of 60 progresses, the SGLT2 inhibitors in the kidney start decreasing. So the efficacy of this drug starts decreasing. Coming to the care, functional assessment, depression, cognitive, risk fall, all these things have to be taken care. No alcohol, no smoking, screening of cancer, taking proper care of blood pressure, general health checkup by getting an ECG, lipid panel, bone density has to be done, and ultrasound and diabetes screening even for non-diabetics. Looking specifically for nephropathy, neuropathy, retinopathy, because the patient, if he is walking around and if he stumbles and he hits, definitely there will be a problem and he might land up into a diabetic foot. So this has to be taken care in our population, and nutrition, medical nutrition therapy is actually working wonders for diabetic population, and we have got a very nice nutritional, nutraceutical things available in the market for all these type of population. So looking to the overall health of group, overall health category in the patient categories, when we come to the group 1, group 2 and group 3, where the patient has got no comorbidities, only diabetes with an A1C of 10.5 with good health. Intermediate, where he is having early dementia, mild cognitive impairments, and then finally coming to a poor health, where there are lots and lots of complications and moderate to severe dementia. Use of drugs that may cause hypoglycemia. When the fasting is somewhere on 90 to 130 and the A1C is less than 7.5, we need to be very, very careful when we are using sulfonylureas. These are the drugs, and when we are using insulin. Basal insulin does a very good job in these type of patients. Coming to group 2 or the intermediate health, where the fasting and the PP, where I'm again coming, when the A1C is coming up to 8, this is where, yes, we should not use insulin and sulfonylureas. And somebody whose fasting is 100 to 180 and a bedtime blood sugar comes to 110 to 200 with an A1C of 8.5 or 10, between 10. Here this is where the hypoglycemic chances are less, where we can be using 0.5 milligrams of glimepiride twice a day or 1 milligram glimepiride once a day. And yes, when we are using sulfonylureas, when the fasting is very high and it goes on, then this turns out to be much better. The International Diabetic Federation Management of Older People with Type 2 Diabetes has given a global definition, global guidelines. Category 1 turns out to be those who are functionally independent. Nutrition is very, very important. Functionally independent people. Consistent amount of carbohydrate should be provided with each meal, and the meal plan should include sugar in moderate amounts, but excess sugar like soft drink or food drinks could be avoided. In functionally dependent, encourage the consumption of adequate amount of liquids, fluids to avoid dehydration. Education and training is essential. Coming to the subcategory A and B, with those who are frail and those having dementia, nutritional assessment should be identifying the presence of malnutrition and weight loss. Already a frail patient, we need to take care of high protein diet, high protein intake, but with a creatinine of 1.5, the protein has to be adjusted. Healthcare professionals and caregivers should identify the actual potential eating difficulties in this population. The teeth and all these things have to be, the gingiva have to be, and caregivers should provide support at meal times so that the agitation gone. And end of life care in the hospital has to be as best. Looking to physical activity, a little bit of mild to moderate physical exercise is better. I'll try to finish off fast. And coming to frail and dementia patients, physical activity has to be restricted because we need to prevent any falls. Coming to cardiovascular risk problems, the functional dependent population on the frail and dementia has to be taken care because of a low ejection fraction in these type of patients. So coming to the glucose control management strategies, first line definitely we give metformin, and we give a DPP-4 inhibitors and a sulfonylurea in a low dose, and what should be avoided is usually a carbose, insulin, SGLT2 and thioglycerides. And considering the second line dual therapy, we need to add on, we can go up. And looking to the medication of choice, looking to the renal function, low hypoglycemic risk by sulfonylurea of 0.5 and 1, medication side effect, potential harms, the beneficial use, cost and availability has to be taken care. So diflumic target has to take care of the frail dementia patient, and you have to use more of bioguanonides, DPP-4 and individualized insulin treatment for these patients. Anti-diabetics not recommended in frail patients, sulfonylureas in high dose, meglitides, tiaglitazones, GLP-1 agonists and SGLT2 inhibitors. So this is where I like to end my talk. I tried to be as brief as possible.
Thank you, Dr. Ashish, for such a nice talk. Since we are running short of time, so no discussion. So
There is a question for Dr. Ashish that this topic was specifically about the lean elderly patients. So what do we mean by lean? Does this not apply to the elderly patients who are not lean?
Basically, most of the population, I was given specifically a topic to look onto the lean patients, and lean patients are those patients who have got lots and lots of sarcopenic effects, lots and lots of muscle degeneration has gone down. So these are the patients where we cannot use the routine drugs which we are using. And here we have to look that hypoglycemia can be caused very fast in these type of patients. And specifically it has been given when the HbA1c is 10.5. And we give in a routine dose of 2 milligram of glimepiride, suddenly they have a hypoglycemic attack. So this is what has to be prevented. When we come to somebody who is morbidly obese, in these type of patients, definitely there is some of the other fat cushion. We can use some other medicines. We can use bioguanides in a longer way. We can use SGLT2 inhibitors. We can use certain drugs which can cause weight loss also. So here the treatment turns out to be very different. Now these frail patients, they are very, very prone to have some sort of a fall, or they are more those who are single or alone, and those who don't have their parents or their children along with them. So these are very special population which has to be taken care in a very different. And medical nutrition is lacking in these type of patients because of their food habits and whatever the caretakers. So this is why we need to have a special thought.
thank you, Dr. Ashish. I would like to invite our next speaker, Dr. Abhishek Kumar. Dr. Abhishek Kumar. नहीं, नहीं, नहीं.
Thanks, Chairperson ma'am and sir. Respected Dr. Raya sir, our seniors and colleagues. The topic is given to me by Vermani sir, is diet in diabetes. What are the myths and what are the facts? Truly speaking, probably this is first time that I am dealing with this type of topic, because if you talk about the diet, there are more controversies than the recommendations. And so let me do my presentation, and I hope I will do justice with my talk. This is nothing to say in this slide. We already know that we are going to be diabetes capital, and the situation is that all is not well in our country, because about 9 to 10% are diabetic and 9 to 10% are pre-diabetic also, and it is growing day by day. So despite all efforts, starting from the diet to medicines to insulin and to other therapy, nothing has proven much effective. Still the control is poor, for which administration, patient part and doctor part all are involved. If we think about the diet, then the question comes in our mind, does diet causes diabetes? A simple question to general public is that I am eating more sugar, I am going to be diabetic or not? The answer is not so simple. We have done so many research, but the clear answer is not there. But definitely one thing is there. Since diabetes, and especially type 2 diabetes, is a part of the metabolic syndrome, and metabolic derangement remains a center point. So definitely diet is going to give us the contributors, they are the contributors in the metabolic disturbances. If you see the our parts, we adopted the Western culture and all other pattern of diet. We reduced our traditional Indian meal, and what we are getting? We are getting the diabetes, more diabetes day by day. So probably first controversy or first myth is this: does the eating more causes diabetes? The clear answer is probably no, but yes, the other component of metabolic syndrome is we are getting, so it is indirectly causing the diabetes. The impact of diet on diabetes is probably known before the era of the medications. We know our giants like Dr. Jocelyn and Dr. Frederick M. Allen. They published their article in 1919, about 100 years back, about the role of diet in controlling the diabetes. And we all know that dietary advice remains the first and the foremost advice in controlling the patients. If we look at the pre-diabetic also, then there are now growing evidences that yes, the diabetes can be delayed if we add a strict dietary plan, in fact a lifestyle changes to our patients. There are many studies like the Finnish diabetes prevention study or diabetes prevention program which has shown that there is a great reduction of chances of developing diabetes in pre-diabetic patient if we stick to the dietary plan. In our part, that is the Indian diabetes prevention program also, we have found that the de-acceleration of conversion of pre-diabetes to diabetes is there. So there came the recommendations. The recommendation for pre-diabetic is also the same, except there is controversy still on the point that whether should we add micronutrients or not. Definitely it is not in the any guideline or much of the guideline, but of course giving micronutrients will give us the good health, and that will indirectly help in management of diabetes. Despite all that, something is still missing, something is controversial. If you look about what are the diets advised since 1900 to 2005, there are various type of diets advised to our patients. Still, if we look the consumption of carbohydrate, fat and protein since past 30-40 years, then we say that there is there is an increase in consumption of carbohydrate despite all hue and cry across the world by various societies including us, and thereby there is an increase in obesity. We all know that the two diseases, obesity and diabetes, are very much correlated, interrelated. Whether we hit diabetes first or obesity first, we have already talked about 2 days back, but we can see that the rising obesity is a menace for the management of diabetes. The most controversial thing or a myth or fact of what we call that what should be the carbohydrate intake, and almost all guidelines much focused on the carbohydrate intake starting from 1979 till date. To know the amount of carbohydrate, we must know the glycemic index and the glycemic load. Since we are talking about the time and range, definitely the high. So while planning our diet, the first controversy always remains what should be the amount of carbohydrate. We may stick to our guideline about 40 to 45% if we talk about the low carbohydrate, or generally if we talk about the RSSDI or other recommendation, it is around 50 to 55%. What we must think about the items, the food items which are having the low glycemic index. The low glycemic load less than 10 are like the high rich fruits and the vegetables and the whole grain bread or the brown rice. There is a controversy whether should we take more bread or more rice in our food. Again, the answer is there in this slide. Rice and bread having the almost similar calories. It is the whole grain which is important. Rice is not a culprit and bread is not our just a miracle to us. We have to keep in balance the rice and the bread, but we must think about there should not be more refined rice and the more refined bread. We should avoid the white rice, white pasta, the sweetened fruit juices and high sugar beverages, including our Coca-Cola like material, which is having about 14% of the sugar. So the myth is that starchy food are not allowed to the diabetes. If we talk about the starchy food, including the common item like the potato, of course it has a starch, but it is also rich in the essential nutrients which is to be given in our diet. So we have to choose the high fiber, low carbohydrate food to get the vitamins and mineral of our need. I talked about the carbohydrate. Are the carbohydrate enemies? The answer is absolutely no. But the type of carb and the amount of carb, keeping in mind the glycemic load of that material, has to be calculated and has to be think about. So we have to choose with the low glycemic index carb, but we have also consider the other thing like the nutrition profile, maturity, and especially in yes, it is true that some are containing more natural sugar. Thus we have to choose the low sugar fruit, and we can enjoy any fruit, but we have to cut short the portion and think about the portion. The third controversy, which is very common and a common myth, is that all the sweetener are good. Many patients are having canagliflozin and all semaglutide like molecule.
Dr. Abhishek,
And
5 minutes, sir.
okay, ma'am. And they are thinking that yes, they are switching the sugar with artificial sweetener. This is not true. The sweetener in our market is not regulated, and many sweetener, including many products like cough syrup, what we call the cough syrup, is free. Many gastric antacids are sugar free. Truly they are not sugar free. We all know that it is on practice. So the recommendation, if we talk about the RSSDI and ICMR, recommendation again is the 45 to 65% of total carbohydrate with 10 to 15% of the proteins and the fat with the low less than 20% of the total body fat. If we talk about the micronutrients, the RSSDI strongly recommends about the micronutrients. They say that the inclusion of micronutrients like the chromium, alpha lipoic acid, magnesium, zinc are adjacent to the standard care, which is not there in the aid. Now we are going to advise diet without any controversy or with less controversy and less myth to our patient. Then we think about what the patient we are getting. See this patient in my OPD, a young male with irregular diet habit, with BMI 28 and blood pressure around 150 upon 90. In investigation, we can see the SGT, SGPT level is raised, dyslipidemia is there, with fasting sugar and A1C in the range of the diabetes, with more uric acid. So it is not just the diabetes. We have to advise diet to check all components of the diabetes. So we have to give the structural meal plan with less controversy, less confusion to our patients when we advise and plan the diet for our patient. Then what to choose? It all depends upon in which region we are. In North Indian, we have to reduce the number of rotis or the rice, increase the vegetables. So white rice, brown rice, what I talked about has to be adjusted. Again, in the other parts of India, like in South India, we always take idli and all. So millets can be added in idli, in preparation of idli. And we can increase the vegetable and the other salad portion. In West India also, we are probably mainly in the rice bound. So we have to think about these products and advise the patient accordingly. So just I talked about the recommendation. The latest one which usually comes in our mind is the LAI recommendation. Again, it is almost similar, that 50 to 60% of the energy intake should be from the carbohydrate, with 10 to 15% protein, fat around 15 to 30%, with trans fat nil. So we are now promoting the Indo-Mediterranean diet with lots of fruit, vegetable, whole grains like unpolished rice, whole wheat and millets. Fatty fish for non-vegetarian has to be avoided. The nuts has to be added in each and every meal plan. We have to advise patient, we have to say patient that yes, you can eat each and everything. Nothing is absolutely contraindicated in diabetes, but you have to eat for your life, not for the disease. Thank you.
Thank you, Dr. Ashish. Uh, Thank you, Dr. Abhishek, for excellent talk. So we are running short of time, so we will not discuss. So I would like to invite all the speakers, Dr. Santosh, Dr. Ashish, and Dr. Abhishek is already on the stage. Please come to the stage.
Sir, they can take it on rent for the photograph. You can hold it. With the promise of returning it. Thank you so much. Now, moving quickly to the next session. To chair the session, I would like to call upon Dr. A.K. Arya, Dr. Mrityunjay Kumar Singh, and Dr. L. Srinivas Murthy from Bangalore to chair the session.
Okay, good morning and a very warm good morning to all of you. And shall we start?
Yes, I was about to say.
So, as a
Good morning, everybody. Thank you, sir, and I would like to thank Dr. Anil Virmani, sir, for giving me this opportunity. So, last 2-3 days, we will be hearing about hypertension, diabetes, cardiovascular diseases, and risk factors. But this is somewhat different topic given to me by Anil Virmani, sir. That is endocrines that interfere with the hormones. Action have identifiable key characteristics that relate to their ability to interact with the key regulatory systems in the hormone system, that is hormone synthesis, hormone action, and hormone release. So these key characteristics can be used to identify these endocrine disruptive chemicals. There are, as of now, 10 key characteristics have been identified. So based on their mechanism of action, the 10 characteristics, the first one is key characteristic 1, they can interact with the receptors. Key characteristic 2, they can act as endocrine hormone antagonist. They can alter the receptor expression, like signal transduction, including the changes in the protein or RNA expression, post-translation modification in the hormone responsive cells. They can also alter the epigenetic modifications in the hormone producing or hormone responsive cells. They can alter the hormone synthesis, hormone transport, hormone distribution, and circulating hormone levels. They can affect the hormone clearance by preventing the breaking down of the hormones, and also they can alter the fate of the hormones in both hormone responsive and hormone producing cells. So now coming to what are the effects of these disruptors on endocrine glands. So every endocrine axis may be target of each endocrine disruptor. That means one endocrine disruptor can act on one axis, or it can act on multiple axes, or multiple compounds can act on a single axis. So the action is not limited to single axis or organ. And among this, hypothalamo-pituitary thyroid, hypothalamo-pituitary adrenal, and hypothalamo-pituitary gonadal are the more common targets of these compounds. And this can affect the central nervous system, impairing hypothalamic and pituitary functions, thereby disrupting the power actions of peripheral glands and with unclear effects. So also they can disrupt the metabolic homeostasis, altering the adipose tissue, thereby impairing endocrine regulation of adipose tissues and adipocyte production. There is an increase in the size and number of adipose tissue. So reducing the basal metabolic rate and changing the regulation of appetite and satiety, resulting in weight gain. So these substances are often referred to as obesogens, and this predispose individual to weight gain despite following a low caloric diet and increasing. So many patients come to us say we don't eat anything, we are working out, even then we are not able to lose weight. So this is because of this exposure to these endocrine disruptive chemicals. So with the knowledge of these chemicals, we can answer the questions of many patients, what we term as idiopathic. Maybe these chemicals are responsible for these problems. So now coming to individual glands, pituitary gland. So this system presents a preferential target for endocrine disruptive chemicals, which may alter the proper function of the CNS, mimicking neurotransmitter actions, besides their ability to bind to endocrine receptors. So several endocrine disruptive chemicals act on the pituitary gland, influencing the different endocrine axes. As a result, a wide spectrum of clinical manifestations have been associated with exposure to pollutants, such as precocious or delayed puberty and circadian disruption. So now reproductive system, as the chemical structure of these chemicals mimic the most of the sex gonadal hormones, the reproductive system is the most vulnerable endocrine axis to this endocrine disruptive chemical action. So the US Environmental Protection Agency described 5 classes of these compounds as having anti-androgenic properties and weak estrogenic activity. One is drugs or synthetic estrogens, phytoestrogens, pesticides, plasticizers, and industrial substances and their byproducts such as phenols, dioxin, heavy metals, and flame retardants. So the exposure to these chemicals damage the developing ovary by interfering with the various processes in the female reproductive system development. So early, that is in the postnatal exposure to this compound may result in significant changes in the genetic transcription of somatic cells, altering the proper timing of physiological process, resulting in either precocious puberty or delayed puberty. So these substances have a consistent role in decreasing both male and female fertility, and the testicular hypertrophy and PCOS have been associated with the endocrine disruptive chemicals. Now coming to testicular dysgenesis syndrome, impaired spermatogenesis, undescended testes, hypospadiasis, testicular cancer are some of the symptoms of testicular dysgenesis syndrome. It is a result of an interruption of physiological embryonal programming and gonadal development during fetal life. In most severe forms, there are very low testosterone levels and develop testicular cancer when compared to milder forms. So some chemicals like phthalates, vinclozolin, acetaminophen play a significant role in the onset of testicular degenerating syndrome. Again, in female infertility, long-term exposure to endocrine disruptive chemicals play an important role in the onset of endometriosis and ovarian pathology. Again, phthalates, diethylstilbestrol, bisphenol A are involved in the onset of endometriosis in almost occurring in 10% fertile women and rendering almost 50% of them infertile. And ovarian pathology, exposure to these chemicals like PCB, phthalates, DDT, methoxychloride are responsible for ovarian pathology. Adrenal glands, again, they
Dr.
have
Alam,
Yes,
3
sir.
minutes more.
Yes, sir. They have structural and functional features that make them ideal targets for increased blood flow, lipophilic structure due to high content in polyunsaturated fatty acids in cell membrane, and presence of cytochrome P450 enzymes and free radicals. So even a partial impairment of improper adrenal function may have severe effects on human health. So the most common effect is interfere with the biosynthesis and metabolism of steroid hormones in the modulation of inhibition of enzymes involved in steroidogenesis. So these xenoestrogens impair adrenal function by inhibiting the enzymes aromatase, 5-alpha reductase, hydroxysteroid dehydrogenase, which play an important role in the adrenal steroidogenesis. So coming to thyroid gland, iodine plays an important role in the biosynthesis of thyroid hormones, and sodium iodine symporter transport ions inside the thyrocytes. So this perchlorates and thiosonates affects the metabolism, inhibiting the sodium iodine symporter. Again, this explosive fertilizers and airbags contain high amount of perchlorates. And thiosonate is present in cigarette smokes and Brassicaceae family, that is cabbages and all this. That's the reason we advise patients not to eat these foods, particularly in the breakfast. And iodine supplementation in pregnancy and in children may protect from the actions of these endocrine disruptive chemicals. Again, these endocrine disruptive chemicals play an important role in developing many various endocrine cancers like testicular cancers, thyroid cancers, breast cancers, and prostate cancers, apart from other cancers. So, how do avoiding endocrine disruptors? A proper identification of these products, classification and labeling and packaging regulations will help in avoiding these disruptors. Strict management and approach to risk management, that is implementing laws so that these products are consumer products are free of these compounds. Precautionary principles, apply the principles before allowing these chemicals to enter into the commercial market. Empowered consumers, educate the general public about the harmful effects of it. Implement the preventive methods. Industry and agriculture, providing the industry and farmers about the knowledge about these chemicals and providing incentives to use these EDC-free products. Thorough research to gain a knowledge about more amount of products, and also research on developing products which are this disruptor-free. So to summarize, these are the exogenous chemicals that interfere with the hormone action, increasing the risk of adverse health outcomes including cancer, reproductive impairment, cognitive deficits, and obesity. The mechanisms by which hormones and the substances exert specific actions are dependent on specific actions at the cellular and tissue levels, as well as on circadian rhythms, seasonal changes, lifestyle, and sex. These industrial chemicals can reach into the soil, groundwater, and make their way into the fish, animals, and ultimately to the human body. Key characteristics relate to their ability to interact with the key regulatory steps in the hormone metabolism, and these key characteristics can be used to identify the endocrine disruptive chemicals. So every endocrine axis may be a target for each endocrine disruptive chemicals, and the action is not limited to single axis or organ. Bioaccumulation of these compounds in the adipose tissues may generate a cocktail effect with clinical effect that may be observed only after several years of low dose exposure and can be seen in the future generations. The best way to avoid exposure is to check labels and avoid products with known endocrine disruptive chemicals. Thank you.
Thank you, Dr. Alam. It was an excellent talk. Friends, please put your hands together for an excellent talk by Dr. Alam. We will not have any queries or questions now. So thank you so much.
Thank you, sir.
So moving on to next talk. Next speaker is Dr. K. Mugundhan. He will talk on metabolic encephalopathy. He needs no introduction to this CCDSI gathering. So please, sir, dash is yours.
Good morning to all of you. First of all, respected chairpersons, first of all, I thank Professor A. N. Roy and Dr. Virmani sir for giving me this opportunity to talk on metabolic encephalopathy. All of us know metabolic encephalopathy is often referred to as toxic metabolic encephalopathy. It's a diverse array of systemic conditions that result in global cerebral dysfunction in the absence of structural brain injury. It's often multifactorial because of the interaction of different organ systems. All of us know it can present as acute confusional state, reduced level of arousal, delirium and coma. So how to identify metabolic encephalopathy? It's very important to distinguish metabolic encephalopathies from structural and electrophysiological neurological injuries. Number one, acute or subacute onset concordant with organ system dysfunction, a fluctuating course, lack of fixed neurological deficit. There can be tremor or astraxis or multifocal myoclonus, relative sparing of cranial nerves, and the important thing is preservation of pupillary function is the hallmark of metabolic encephalopathy. But the people can be involved in case of anticholinergic drug toxicity and advanced wernic and hepatic encephalopathy. So what is the pathophysiology of metabolic encephalopathy? It depends on the cause. The main mechanism is due to the disruption of arousal centers in the brain, that is ascending reticular activating system. See, that another mechanism is dysfunctional of areas critical for memory, attention and the executive functions. Then abnormalities in the neurotransmitters such as GABA, dopamine, tryptophan and cytokines, etc. also affect these connections. So these are the major causes of metabolic encephalopathy, like organ failures, electrolyte imbalance, endocrine, nutritional, infection, toxin, systemic and alcohol withdrawal state. So what are the factors which lead to hepatic encephalopathy? One is hyperammonemia with astrocyte swelling and dysfunction leads to vasodilation and cerebral edema. Then increased sensitive to glutamine and GABA, which are inhibitory neurotransmitters, and low threshold for the seizure activity. So these are the stages of hepatic encephalopathy. I am not going into detail. So MRI will show the excessive deposits of manganese can be present in liver disease, especially in T1. Usually T1 will be hypo in conditions, whereas in these conditions, the hyperintensities on globus pallidus and midbrain in T1 weighted image. EEG can show triphasic. It's the hallmark of the finding of hepatic encephalopathy. Milder forms can show slowing of waves. So the management, one is management of cerebral edema, the elevation of the head end, and keep the PCO2 between 35 and 40 in osmotic therapy. Seizures can be managed. The best AED is levetiracetam. Hyperammonemia with lactose and antibiotics and N-acetylcysteine. Next is uremic encephalopathy. The main pathology is decreased clearance of osmotically active toxins, electrolyte imbalance, seizures, myoclonus, dysequilibrium syndrome, dialysis, dementia, and cerebral atrophy. Seizures and myoclonus, which can occur in uremia in 14 to 30%. It can be focal or generalized. Multifocal myoclonus can occur with uremia. So the EEG changes are diffuse slowing and frontal intermittent rhythmic delta or theta waves is seen. The phenytoin is frequently used in patients with uremia. So we should not load with phenytoin. So we have to give 3 times a day because of a shorter half-life, and it is minimally dialysable. The other antiepileptics like valproic acid, levetiracetam can be given to control myoclonus. Dialysis dysequilibrium syndrome is characterized by headache, nausea, myoclonus. The dialysis disequilibrium can occur up to 8 hours after dialysis, can take several days to spontaneously resolve. Dialysis dementia which is now rare because of changes in dialysis technology. It usually by using dialysis water supply with greater than 20 microgram per liter of aluminum has been linked to dialysis dementia. So it is now rare because of the changes in dialysis technology and near modality. The other manifestations are cerebral atrophy and intracerebral hemorrhage. The next common is septic encephalopathy, which occurs at about 70% of patients with bacteremia. The cause is multifactorial due to inflammatory mediators, the cytokines, by stimulation of the vagal pathway or circumventral organs. The markers of brain injury, such as neuron-specific GNLase and S100 protein, have been detected in patients with septic encephalopathy. Seizures, both convulsive and non-convulsive, can occur in 10% of patients with sepsis. I have two cases. One is case number 1, a 50-year-old male who is an alcoholic, admitted with acute onset of blurring of vision and unsteadiness while walking following binge drinking. The examination revealed he was confused. He has got bilateral internuclear ophthalmoplegia with upgaze palsy, right more than left, with ataxia. The video is not functioning. So the MRI showed hyperintense lesion in periaqueductal area. The diagnosis, all of us know, it is Wernicke's encephalopathy. He was treated with injection thiamine. So the Wernicke encephalopathy is a triad of confusion, horizontal ophthalmoplegia, and ataxia. It can be reliably detected by measurement of erythrocyte thiamine transcriptase in the form of thiamine deficiency. The main pathology is in the mammillary bodies and periaqueductal gray matter and thalamus. It can be treated with 500 milligram of IV thiamine over 30 minutes, 3 times a day for 2 days, followed by 500 milligram of IV or IM each day, 5 days, along with other vitamins. Case number 2, a 35-year-old lady, known case of lupus nephritis, presented with seizures, altered mental state. The admission with BP was 190/100. So the MRI shows there is hyperintensities predominantly in bilateral, parietal, and occipital lobes. So the diagnosis is PRES, that is posterior reversible leukoencephalopathy syndrome. So the therapy, it can be treated by lowering of blood pressure, the loading dose of the phenytoin, followed by the maintenance can be given for seizures. Then we have to control the blood pressure. So that is the main management. Pulmonary encephalopathy is caused by respiratory insufficiency from mixed etiology, often with the complication with the systemic infection and CCF. The clinical presentations are headache, ataxia, confusion, drowsiness, stupor, and coma. Then Hashimoto's encephalopathy, the features are confusion, somnolence, myoclonus, tremors, and so on. The pathophysiologies include autoimmune cerebral vasculitis, global hypoperfusion, brainstem vasculitis, and demyelination. Here again, the EEG abnormalities which show slowing and frontal intermittent rhythmic delta wave, which is called FREDA, and sometimes triphasic waves. Then commonly, encephalopathy can occur due to electrolyte disturbances in the form of hyponatremia, most common, then hypoglycemia, hypocalcemia, hypernatremia, hypophosphatemia, and hypermagnesemia. So the rational approach to evaluate metabolic encephalopathy: first, a complete history including a thorough medical history, details of possible toxin exposure should be performed. Next, we have to ask for sedatives and toxic medical conditions which should be discontinued. Third, the neurological examination can be conducted after appropriate sedative washout period to identify any focal features or localizing signs. So we have to do basic lab tests to identify metabolic abnormalities. Then we have to do blood biochemistry, urine toxicology, thyroid function test, thiamine, serum cortisol, and vitamin B2 levels. Imaging of brain on the basis of examination and lab results. Then lumbar puncture in case of infective conditions. Continuous EEG monitoring is a emerging field. It is done to evaluate seizures or non-convulsive status in case of unexplained encephalopathy. In command following patients, 95% of seizures will be captured within 24 hours of monitoring, but only in 80% of seizures are detected after 24 hours of monitoring. So 48 hours of continuous EEG can be required in comatose patients. These are the differential diagnosis of metabolic encephalopathy.
Sir, kindly conclude.
Yes, sir. The current treatment paradigms focus on supportive care and the treatment of underlying etiology. Prognosis, the brain dysfunction occur with metabolic encephalopathy were thought to be completely reversible. The persistent neurologic and psychiatric deficits can occur in 30% of survivors. So I conclude my talk with the following points. Organ system failure like hepatic encephalopathy, hypoxia, electrolyte imbalance, endocrine dysfunction are responsible for metabolic encephalopathy. The underlying etiologies are diverse, which can be narrowed down by recognizing the clinical clues. Management includes acute stabilization, specific measures based on the etiology, including organs support. Given if most cases are reversible, have good outcome, delayed diagnosis management can be associated with worst outcome and neurological sequelae. This reinforces the need for urgent diagnosis and management. Thank you. Thank you for the patient here.
Thank you very much for an excellent talk, sir. So because of paucity of time, we will not take any questions.
Yes.
So moving on to next topic.
Well, now may I request Dr. Deepak Jumani sir to please come on the dais, and a warm welcome to you, sir, to GOA and to this conference. We all look forward to listen to you again and again.
It's an incredible opportunity to me to be amidst legendary doctors like Dr. A.N. Rai, Dr. Veermani, and all others. And I am really fortunate to be here amidst you all and share my views, thoughts, concepts, and passion. The topic given to me is really very, very important. Though we all crave for it, we do have it, and we can now know how to get it. The subject of my discussion is sexual bliss. Well, there is no magic wand or pill which can give anyone a perfect sex life, or even the same person through their entire life can remain in that same sexual ecstasy or bliss. Our relationship with sexuality keep on evolving through lifetime, and satisfying sexual experience is an essential part of being healthy and having an enjoyable life for most of us. What works for you today may not work for you tomorrow. What works at the age of 20 may not work at the age of 30, 40 or more. With pranams to God and thanks to my teachers Dr. O.P. Kapoor, Prakash Kothari and Dr. Shashank Joshi, I beseech them to bless me always. I have some disclosures. I am not from Congress, BJP or Aam Aadmi Party. I am not a follower of Asharam Bapu, Radhe Ma, Ramdev Baba, or I am not married to Indrani Mukherjee. I am a pure CCDSI and am passionate to educate the masses on ethical science of sexuality. Mitro, look at our Prime Minister. His hands are down. He gave us GST. He had no other choice. Then he told me, Deepak, so look, my hands are up. I said, I will also offer my GST. And my GST to you all is great sex therapy. Is sex secret? Who doesn't know what is sex? Everybody knows. But we need to understand that sex is not a secret, but a sacred thing. We are all born out of it. It's a creation of God. And intimacy is ageless. But to have ignite intimacy, we need to strategize our mind and body for getting optimum sexual pleasures. In this 20 minutes, I'm going to tell you what is sex, what is bliss, and what is sexual bliss, how will sexual bliss help us, and when will sexual bliss happen to all of us. So what is sex? Sex is duty if it is done with your wife. It's art if you do it with your girlfriend. It's education if you do it with a virgin. It's tuition if it is done with a tuition teacher. It's job if you do it with a secretary. It's science if you do it with a fertile lady. It's business if you do it with a whore. It's social work if it is done with a neighbor. It's charity if it is done with a widow. And it is a sacrifice if it is done with your own hands. But the real fact is, God created it and called it very good. If it is so good, then why are there issues in enjoying it in the God's way? Sex is all about intimacy and is deeply personal. It has to be enjoyed without guilt and shame. It's an illustration of God's relationship to His own people. Sexual purity is a special area to watch out and be diligent in. Today, sexual behavior has been twisted, torn, but sex itself is not ruined by the fall of whatever we are doing in our behaviors. There are rapes, there are so many other wrong things. So sex is to be used and not abused. So this is all about sex. So what is bliss? What is bliss? Bliss is nothing but supreme happiness, utter joy and contentment. And how do we get it? Love is a wonderful tool for this blissness. If we search deep within man, we will find that no other word is used by him more falsely than love. Today, human being is a product of a culture that is 10,000 years old, but the human being is blamed for being wrong, not the culture. It's like fruit is blamed from a tree to be poisonous or to be not good. It's not the fault of the food. Fault is with the seed. So we need to understand it is not the fault with we all. It's the fault with our culture which we are growing in. That has brought all these things here. So this is what we need to understand. Love is an intrinsic in nature and has to be cultivated. More love can be seen in birds, animals, plants, tribesmen who have no organized religion or culture. But we are more evolved. We are more intelligent. And the first thing is that until unless now, human culture has been against sex. All cultures, all religions, all gurus, all holy men, they projected sex as sin. But the evolution of love is nothing but a transformed sex energy. It is just like how coal becomes diamond with the passage of time. Is it not? Coal becomes a diamond. If lust is transformed, sex can become love. As simple as that. So, evolution of love is nothing but transformed sex energy, and the barriers to this are man-made. If love is suppressed, when religions proclaim that sex is unsacred and hence it has to be controlled by one's own effort, it is suppressed. Friends, we all have learnt in our science, suppression ultimately makes it to come out many times more intensely. We try telling patients, tum khana band karo, ye karo. He tries to control, but suddenly, all of a sudden, he binges on food. So we've seen that it comes out more intensely. In sex, if you suppress, it comes out as obsession. Thus, people they become more neurotic, more pervert with anger, aggression, crime, etc. This is because it is the same energy that has taken an alternate manifestation due to centuries of suppression. What is sexual bliss? Let's come to our topic of today. Sexual bliss is defined as happy and fulfilling sexual intercourse and bodily pleasure that occurs in a passionate and monogamous relationship with a loving partner. This is a definition of sexual bliss. When we look at orgasms, what happens? Two things happen. First, in that moment of orgasm, the ego vanishes. Absolutely, we are not ego. Second thing that happens is that for a while we become timeless. There is no time. We don't think about past, we don't think about future. We are in that present mind. And this unconsciousness state is what is called as bliss. Same is with a man. Nothing is more important than reconnecting with your bliss. Nothing is richer than that. Nothing is more real. Same is with men when he gets orgasmic. So the truth is, when man reaches the climax, or a woman reaches a climax, he experiences that mind has become empty of thoughts. This is the showering of bliss. It is only in that moment of love making that human beings realize for the first time that so much bliss was possible. This emptiness of the mind, when he becomes thoughtless, this disappearance of thoughts is the cause of the showering of divine bliss. Thus, human beings came to experience that the mind can be stilled and the mind can be freed of thoughts and experience this bliss. The central element of in normal life of human beings, God, soul, truth, it's not all that. If we look closely into the nature, we will find that there is only one wholehearted process going on. It is one of the continuous creation of procreation, of continuous resurrection of life in newer and newer forms. Leave about human beings, forget human beings. Let's talk about vegetables. There is nothing else more important in human life than his urge. However, it has been idea of sexual activity is regulated by just a bit of shameful and being dirty. This is cultural thing which has been imbibed in us. While one can appreciate the contention that it is rather a private affair, surely the amount of embarrassment attached to it is exaggerated. Our sexual attitudes, including what is considered lawful, is a phantasmagoria of hypocrisy. Sexual hang-ups or insane rulers through the ages confused morality and obscure precedents, most of it's dated around Catholic Church. So homophobia, misogyny and sheer wrong-headedness started to develop right from the Christ or the church fathers which they did. It's comprised of mind, body and spirit. Simply allowing our bodies to experience the juicy divinity of sexual pleasure and deeper intimacy can take us to ultimate healing, bliss and liberations. Sex can be incredibly positive and beautiful. Mindfulness, remember friends, mindful sex, which means being passionate, being connected, being involved only in your partner can do it. And we can all do it, we all like it to do it. For which, how do we attain? How do we become sexually blessed? What men have to do in their relationships? They have to make her partner feel on the top of the world. Agree with her. First do what she says. Smile and keep your mouth shut when she's talking about something. Encourage her to discover her hidden talent. Give her time, not gifts. And feminism needs to be adored, respected, admired and trusted. If you do this, she is forever in love with you. She will give you all the bliss what you need. And what they should do, what women should do, they should regard their partners as hero and never give them any pressures to perform. Yeda hai, teda hai, lekin mera hai. So, and if she does that, he is forever happy. And you have to look at yourself. Don't worry about whatever you are, howsoever you are. You are a sexual being. Accept yourself the way you are. Just come out of the monad. We all have been changing. We all have been varying as we age. So variety is the spice of our life. Variety is what is constant which we all look for. We were not same 5 years ago. We are not going to be same 5 years from now. So please understand the nature of life is variety. So we all humans love variety. Break the monotony. You can use toys. Become erotically intelligent. Look at your partner's inner beauty. Don't change yourself. Don't talk about your spouse as to what do you like. Ask her what she wants. Don't be afraid to ask questions with her. Have you explored your partner's in full potential her body? No. Explore her body. Explore every part of your partner's body like it's the first time you're doing. And every time, try new things in bed. Be fearless, carefree and playful even in the bedroom. Express spontaneity. Love each other unconditionally. You all are partners for life. You can't change the time. So you are obese. What? So what? Nothing wrong. But you can learn to swim. And commitment is the important thing and the most important male mileage. Bring in harmony. Try and control your metabolic syndrome completely. It is all in our hands. Science have proved, Dr. Veermani proved so many times that there can be remission of diabetes. Even reversal may be in the pipeline. Hypertension can be brought under control. Dyslipidemia can be brought under control. We can counsel our patients to de-addict with smoking, alcohol and all so many things. Reduction of stress is so easily done today. Meditation, yoga. We have got so many strategies to become normal. So try and attain, manage your risk factors, give them a U-turn. Lifestyle modification. You may be Hindu, Muslim, Sikh. Learn to be making your lifestyle modification as your first religion. My Dr. R.D. Lele has given so many strategies of improving your lifestyle, how to eat. Sex is an important part of the balanced diet also. We look at a woman, oh, she's good, she's because of her figure, because of her height, because this concept has to be totally, this myth has to be ended. The first step in updating your beliefs around sexuality is to think of yourself as a sex subject rather than a sex object. So my take home is keep sex sexy. If you are able to have sex, you will never get coronary artery disease because your penile arteries are open. They are the smallest arteries in your body, and if those are open, the larger arteries can never be blocked. So you cannot have coronary artery disease if you are sexually active. So keep sex sexy. Monogamous marriage is like a garden and polygamous relationship is like a jungle. Both are beautiful, but for a garden to make beautiful, you need to give time, you need to put the right type of water, fertilizers, etc. So Voltaire beautifully said, try and cultivate your own garden. And it's a choice you have, whether you want to be a gardener or a jungli. Choice is yours. It's not about love, it's about understanding each other. And unless we love and are loved, we all will remain alone and deeply lonely. Physical intimacy and emotional intimacy are the true roots of love and sexual bliss. That which divides us is just in our mind itself. So the key to having good sexual health or being sexually blessed is give time, quality and quantity time to your partner. Trust her, try and adjust. Sex is not secret, it is a sacred song of the soul. Sex is a sanctuary of your own self. Sexual bliss is all in the head. How you manage your sexual functions is a choice we all have. So my take-home message is very, very important. The existence has given an opportunity to human beings through sexual orgasms to experience and realize what blissful state of mind is. We all have experienced that. It is possible to live continuously in the same blissful state, not only by correcting our own bodies, by correcting the metabolic syndrome, etc., and also through meditative practices for a longer period. Transcending sex and not suppressing is essential to achieve this blissful state. And hidden deep down in sexual urge is the soul search, which is largely unconscious. This comes to conscious awareness through a proper understanding of sex, which happens when the ego is dropped and sex is viewed respectfully. Hence, sexual bliss is attained and it transcends. Thank you all for your love.
I am sure all of you would agree that after an excellent talk of Dr. Jumani sir, only two things can happen. Either there will be no questions or there will be many questions. So we will have the pleasure to interact with you in future, sir.
No issues, sir.
Due to the
Thank you.
paucity of time, we enjoyed, and thank you once again so much.
My pleasure.
Thank you,
Thank
sir.
you very much.
May I invite all the speakers, please, on the dais for the memento.
Dr. Arya has not been given, so I request Dr. Deepak to kindly. I request Dr. Deepak sir to kindly present the memento to Dr. Arya. Thank you, sirs. It was indeed a wonderful session that we just had. And there are so many things that we get to learn, we get to accept, and obviously, the goal is to get proper conjugal bliss. So, with this, we have come to the last rung of this academic ladder that we had started climbing. So we had back-to-back wonderful, breathtaking sessions aptly titled by none other than the scientific chairperson, Dr. A.K. Virmani, and it was really a wonderful package that we are going to take back home and obviously remember this. It is a time to reflect upon. We have come to the validity session. So one thing I can always say that the kind of promise that we are going back with is for especially Virmani sir, that जब हौसला बना लिया है ऊंची उड़ान का, जब हौसला बना लिया है ऊंची उड़ान का, फिर देखना फिजूल है कद आसमान का. So this is how we are going to reflect that where we have missed the bus or whether we have been able to hit the bull's eye. So with this, I hand over this mic to Dr. A.K. Virmani. Thank you.
Thank you, Minati. This is fortunately we have finished before time, and we'll have the validatory function. So I'll invite Professor Dr. N. Rai and Dr. Mitenja Singh to please come on stage. And at the outset, I would request I'll request Professor N. Rai to give his comments.
Dear colleagues, this is the last function. As a chairman of Energy Committee, he is our secretary, and Dr. Virmani, chairman scientific committee. We all take the responsibility of any shortcoming. We tried our best, but we always there must be some shortcoming. We beg excuses if there is any shortcoming. We tried our best. I hope the scientific material, I must congratulate Dr. A.K. Virmani. It was excellent. You all have enjoyed. Hospitality, I think Mithilesh was responsible. We must give credit to him. So hospitality, we tried our best. I cannot say that all of you are 100% satisfied, but we tried our best, and in the future we will also like to improve. Now I hand over mic to Dr. Virmani to advise audience for any comment.
Yeah. I think we should have some comments from the audience, and I will start with Dr. Prabhu. Please give your.
I consider this as a great privilege to be a part of this very happy academic feast. And I am thankful to Dr. A.N. Rai, Dr. Virmani, and all the senior esteemed members of the CCDSI. And this is one of the best conferences I have attended during recent years. Right from the time of registration, from the scientific schedule, the way it is being conducted, and very happy exchange without any politics, and it's really amazing show. Thank you very much, sir.
Dr. Vijay Patni, to please criticize. please tell us our weak points. Here. Mike.
So first and foremost, thank you, Dr. Virmani, for allowing me to criticize. And there's hardly anything to criticize, but yes, Dr. Deepak Jimani coming at the end is a point of worry. So that's one. Number two, this is a true criticism I would like to make. Have you all seen the memento? Have you seen the memento? I don't appreciate. Mithilesh, you should have taken the advice before planning out a memento, because the memento is to be kept as a treasure at our cupboard. And here, unfortunately, you have mentioned Lipul Pharmaceutical Company, which probably CCDSI won't agree with. This is a memento from CCDSI. It should have been like that. I think all of you agree with it. So that's a point of criticism, but take it positively. It's nothing like that. Yeah. Third thing, whenever you are doing it in an exotic location, the planning should be such that we have an audience full, and the timing of the CME should be, I think so, between 11 to 5 or 11 to 6, so that we really have an audience in the audience. Matlab, we need to learn. So there should be someone on the bench, chairs with such speakers. We had excellent speaker today, even whoever spoke and what I was heard, Dr. Abhishek Kumar, Dr. Mohsin Aslam, and so all of them have prepared so well that, and if the audience is there, it would have been great. Dr. Deepak Jibani, we don't have to say anything. He's always excellent and vibrant. So that's, these are the 2 points which I thought could be taken into consideration when I plan out the next time. But excellent scientific content, everything was covered. Excellent hospitality. I think everything was taken care of, right from the airport to, I think people going back to the airport has been taken care of properly. And the rooms of this particular hotel is good. Yes, I think I'll hear Dr. Ashish Saxena, the second person who we might criticize a little bit. So I'll ask, on behalf of yours, Dr. Saxena to come over and give his feedback. Thank you.
Sir, there is no absolute criticism of anything. The content, the things, everything is very well arranged. There are just 2-3 things which I like to point out. First of all, I appreciate the food of this hotel. They have persistently made it possible that for the 3 days we had the same taste and same quality of food, because I think so the diagnosis which I have reached with my colleagues is that they prepared the gravy in one day for 3 days and they mixed everything and gave it to us. So that was one thing. The breakfast has been almost the routine similar. There was nothing new in it. So, and when I entered the hotel, it was good, it was nice, and when I entered my room, there was a peculiar musty smell which was coming, and that was basically of the fungus, because the rooms were not open for quite some time. I do not presume that this is a 7-star or a 5-star hotel, because when I went to the reviews, most of the people have complained the same things. So yes, we can have something different. Pools are available everywhere. I think so hardly 3 or 4 of our delegates had used the pool. So in these type of things, because we come out, we want to enjoy. These are small things which and yesterday it was very embarrassing that our doctors were singing and there was an orchestra which was not partaking with their singing to give the band the music, because music unites, it doesn't divide. So that was one thing. When I tried to point out that person, he brought out a bouncer stand in front of me. This was a private party. So that was the only thing which I said. Content was excellent. Excellent content, and teachers at par. They have taken so much of interest to make slides, and most of the slides were personalized. I don't think so there are any pharma slides. And what I was discussing outside with Dr. Abhishek is how we can grow with the vision of almost 12 chapters, 30 each. Definitely we'll be adding 300 to 400 more people, I was discussing the strategies and ways how we can bring in more people, especially students who can come in. We can have a session on poster and abstract presentation and some subsidized dormitories for them so that they can come in a cheaper way and they can be the part of the audience, because according to the NMC we would require at least 2 paper presentation before you pass your MD. So these are the things which I was highlighting. I would have told personally to Dr. Virmani, but I was being told by Dr. Patni to come in, so I just expressed my views. Thank you very much.
Thanks, sir, for inviting me here. Whatever latency has been lighted out, I do agree with them, with all the things, but whatever can be done, it was done. I appreciate all the colleagues who have presented papers very nicely, very excellently, and I extend my warmest regard to Dr. Virmani, because I have attended so many conferences, but never so much lovely. I mean to say that has come impress the heart, just a lecture of our great personality, who has all removed the tiredness of ours. All the tiredness of ours. We are refreshed now. So sometimes we end the session, we return like that, but we would be returning like a jawai, with encouragement like that. Abhi to main jawan hu. है ना? That is the message of today, end of the conference. And जब प्रोफेसर डॉक्टर प्रोफेसर आया कर रहे हैं तो मानना पड़ेगा सर कि हम लोग जवान हैं. Family will be happy, is correct. On the whole, the conference was successful. Thanks to Mr. Misles, very nice hospitality. Something remains always on the minor sides. Okay, thank you, sir.
If I was to bring down the rainbow from the sky, I would do so, and I would write Dr. Anil Virmani on it and place it back in the sky. I see organizing a mammoth conference like this is not a joke. And to organize it, call people from different parts of our country, arranging the scientific content, negotiating with pharma people, travel, it's a huge task. हम घर में भी, हमारे घर में अगर 5-6 मेहमान भी आएंगे तो हमारे से भी कभी-कभी गलतियां हो ही जाती हैं. You know, in doing hospitality to the best of our intentions. I feel we should ignore everything. Should never talk about it. Nobody intended that pool would be empty. Nobody intended that music wala will not play in synchro with this. Nobody intended that food should not be all that good. ये कोई intent तो नहीं था ना किसी का. Intent was fantastic to call at an exotic place, enjoy, meet, brotherhood, friendship. यही तो intent था. All I can say is I can't reciprocate the honor and the love and affections from whatever I got. But all I can say, sir, to all of you is, seasons may come, seasons may go. Everything fades with time, this all of us know. But one thing which freshly blossoms as fresh as dew is love, respect and affections for you. Thank you very much, sir. I am greatly indebted because I was to come on the 4th early morning, but my mom had a fall, so I requested them to change my thing, and I didn't want to miss this because this is the first year I am attending CCDSI, and I was very, very keen on coming it. So thank you for allowing me to come a little late. Thank you very much, sir.
Dr. Akash, you want to say something?
I thank Dr. Rai sir, Dr. Khaitan sir, Dr. Virmani sir for calling me here and all the organizers of CCDSI. Actually, this is a organization which I deeply respect, and this is organization which has connected me to so many people across India, and I am always obliged basically to come over, attend the meetings of CCDSI, and
not from outside. I am an insider. I'm sorry that I have been out from my core group, which is from Gaya. I belong to Gaya. My mind is in Gaya also. Anyway, all said and done, I will just sum it up in 3 sentences. If I remember, I used to be called low IQ boy in my childhood days. But I was not having low IQ. But I tolerated that one. One thing I have learned coming to this conferences, especially CCDSI, I had only 2 intentions. One, to learn things, whether it is Dr. Avadhesh Kumar Singh, or it is Dr. Ashok Taneja, or as Dr. D.P. Khaitan, or it is a Professor K. Mugundan, or it is from anybody from anywhere, or Dr. Jumani, or Dr. Anuradha Kapoor, or from Dr. Akash Singh, or whoever. I wanted to learn. And I have been learning. I'm still a student. That is number 1. Second thing, I am to have good friends, quality friends. I have. I've achieved through this. And third, I never mind what the type of food and what type of, actually I am set in. I never, my missus always very concerned, but I am never bothered about it. I'm from the beginning, I'm like that. In fact, in toto, I am a useless person in all other activities. Yes, I am definitely, I can devote many hours for the scientific. And probably with the grace of God and the goodness of my senior colleague, Professor Rai, and Dr. Mrutyunjay and many others, Dr. A.K. Virmani has been an inspiring force from the beginning. So, in nutshell, in a conference we come for 2 things, the scientific and also social gathering. We have probably the best. We have been getting it. I'm thankful. And there are many people to whom I say, if I say, you know, our NCD, non-communicable disease, what is the answer? LSM, Professor L.S. Murthy, from whom I have been learning. I say him directly. The newer concept of newer this semaglutide, dulaglutide. Yes, yes. I'm just making it simple. I'm sorry, sir. You have not. I'm not commenting. I'm enjoying this. All said and done, I enjoy this. I always learn. I'll be learning through all of you. Thank you very much. And I'm really, I have been telling before that also. He is an excellent person. He has done jewel of things. I asked him, who are other people who have guided you to make this beautiful scientific year? He said, I knew that he is the only person. So thank you very much, sir. Thank you very much, all of you. Sorry, we have taken your lot of time. And we will be definitely inviting all throughout the seasons and futures to come. Thank you very much.
Thank you. Yes, Dr. Mugundan, please.
I feel very much honored to be here. I'm a neurologist. I was inducted by Professor A. N. Rai even the year 2015. I have been as a faculty in all meetings under Professor A. N. Rai. I must thank Dr. A. N. Rai and Dr. Virmani sir for giving us the opportunity to talk in this prestigious forum. Thank you, sir.
Dr. Murthy, you would like to say something?
Thank you, sir. It's an honor to be here among so many teachers, and that's what I learned, because in all the academic forums we feel friends, academicians, etc. But the teachers, that whenever we see Rai sir or Ketan sir or Virmani sir, of course, young at heart, but he's got all the qualities of teacher. That's what we like when we come, it's like a classroom. So I very sincerely, obediently prepare my slides whenever CCDSI. I've told this on Zoom meeting also. And the love and affection, the CCDI family gave it to me on virtual mode. I mean, everybody looks at a person, gets mingled with the person, then he realizes, okay, this person is okay, reasonable. But the CCDSI family recognized me all through virtual only. That 3 years during COVID, that was the best part in my life. I mean, people can recognize, realize even virtually, and that's the greatness of the teachers which we have. And we are indebted to you, sir, because we will not find teachers like, even I am a teacher, I am a professor at a United in a medical college, but we cannot match your sincerity. The Virmani sir always, he is with a very modest way, he will put pressure. Unlike our teachers who strictly show your finger on your face and they tell you you have to do this. But he'll be in a very diplomatic, hands on your shoulder, but he will make you work. That's the speciality of Virmani sir. He'll be young at heart, and after 6 o'clock, he'll be so young at heart and friendly than any one of us. Forget the age. So that's the qualities which I have learned, to be with the people, to get the work done. And end of the day, it's science and the society should progress. I think we should dedicate ourselves to bring this up in a well academic way. I think that is what we are trying to do, forming the guidelines, etc. And that responsibility is given to me, of course, with a very great team which I'm going to form under the leadership of A.N. Rai sir and Virmani sir. I'm sure we'll do justice to that. And definitely the CCDS family is close to heart compared to all the other academic forums. I mean, other few academics also, organizations also, but this is something which feels like a family because the love and affection given is at a personal level rather than, in a diplomatic academic way, but this is close to the heart. Thank you again, sir, for all the opportunity.
Thank you. I think the whole show was very well organized and conducted by Minati. So we would like to give her applause and a memento also from our side, CCDSI side. And I'll request Professor A.N. Rai to please give the memento to her. And before we end the session with the vote of thanks, I'll request Mr. Mithilesh to give his comments. Mithilesh, please.
Good morning, everybody. Hello. Good morning, everybody. Sir, I am very happy to learn something from Dr. Vijay Patni, sir. Sir, I know learning is never-ending process, and I get your point very well. In next time, certainly that will be changed. And also, you suggested me write the name in back side. It's better to not write the name. So in future, sir, certainly name is not appearing memento. And in spite, yes, it's only CCD, sir. I will write that. That name is not any matter to how to write where, only your heart is the matter. I am in your heart, that is the enough for me. And apart from that, this is a part to look, certainly look this part. But in spite of that, I am busy to so much in conference last 2 months. Sir is knowing very well. Every conference, registration part, every part is myself. And I am going to back today, tomorrow I will in Rajgir. After 3 and 4 days, I will in Muzaffarpur. So that's why something missing. I also felt that. But in future, I assure that better than that. And thank you for your suggestion, sir. Thank you, Virmani sir, Rai sir, and entire CCDSI team, sir. Thank you.
I must also thank.
I request my team, please present memento to Dr. N. Rai sir. Pankaj, please come. Thank you, sir. 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 Sir. May I call Abhishek, sir? Please come and Dax. Last memento for you. One memento. This memento goes to Patna. This memento make in here itself yesterday night. So I call. बस हो गया सर बस. Thank you.
And I must not forget in the end that we had wonderful audiovisual, smoothly run, only because Darvesh Jha came and helped us throughout the 3 days. Darvesh ji, please, a few words from you.
Very good morning to all of you, sir. I'm really honored to have this podium to speak something. In fact, the effort which has been taken by the Mithilesh and effort which has been taken by the entire scientific committee team, I will always have to remember. Yes, someone has said that mistake is being done, but I will definitely assure you in future, whoever will be the sponsor, but it will never repeat it, sir. I'm really honored by the entire scientific program was designed in that manner that in every conference, they were the pearl of the conference, entire speaker. It's a really honor that I am a part of CCDSI in this conference, annual conference of 6th. And I will love to continue participate in the CCDSI. Thank you very much, sir. And I would not like to forget Dr. Birmani, sir, Dr. A.N. Rai, sir, and Dr. Mrityunjay, sir. They have always supported and guided us to how to improve in your day-to-day marketing. Thank you. Thank you very much, sir.
Thank you. And in the end, I'll request Dr. Mrityunjay to give his comments and the vote of thanks.
So every good things which will start will come to an end. So it ends here. So at the outset, I would like to thank all of you for coming here and joining us. Yes, there are certain shortcomings we have also seen, and we will try to rectify it when we will organize next conference. So thank you very much to all of you, and my special thanks to Dr. Birmani sir, how beautifully he has crafted the academic program. He has single-handedly made this program. So a big clap for Dr. Birmani sir. And thank you to all the speakers, all the delegates. Thank you, Dr. LSM sir, Dr. Khaitan sir, Dr. Jumani sir, Dr. Patni sir, Dr. Saxena sir, Dr. Prabhu sir, Dr. Mugundar sir, Dr. Panda sir, Dr. Singh sir, Abhishek, Dr. Mohsin, everyone. Thank you very much to all of you. Thank you. Also, I would like to thank all the madams, ladies who have joined us. And thank you to Meenati, thank you to Mithilesh, Darvesh, and all the team, Lipur Pharmaceuticals team. Thank you to all of you. Thank you. Thank you once again. We will meet soon. Thank you very much.
Thank you.
Long live CCDSI.